Hi, and welcome to the show. Subscribe at kevinmd.com/podcast and get CME for this episode by clicking on the CME link in the show notes. Today, we welcome Landen Green. He's a family physician, and today's Kevin MD article is titled Direct Primary Care, More Access, More Savings, More Care. Landon, welcome to the show.
Thanks for having me, Dr. Phil. I really appreciate the opportunity to be on your show.
So let's start by just briefly sharing your story and journey to where you are today.
Sure. So I'm a board certified family medicine doc. I did my medical school at Campbell University in North Carolina, where I met my wife, who's also a family medicine physician. And that's where I started my own primary care practice using that direct primary care model of care. And my clinic now is called Caravel Health DPC.
All right. So I think your Kevin MD article where you talk about direct primary care, that also kind of goes more into your story. So give us a little bit of a before and after in terms of what your practice was like before your direct primary care practice and some of the motivations that led you to start direct primary care.
Sure. So I actually started the practice right out of residency. It doesn't take very long in the system. Even in residency, you realize that family medicine has changed from what it used to be, and it doesn't seem like it's very authentic or genuine anymore, and maybe the motivations from corporations aren't exactly aligned with the provider's motivations to really take care of patients. And so I felt that I wasn't able to be the doctor that I wanted to be, and probably more importantly, I wasn't able to be the doctor that my patients needed me to be either. Just like doctors are frustrated with seeing 40 patients a day and going home and doing a ton of notes and not spending time with their family. Patients at the same time are frustrated at having to wait 3 to 6 months to see a doctor and then waiting 2 hours in the waiting room just to see a different provider that they've never even seen before. So there's frustration on both sides. And that sort of is what led me to say, you know what, this isn't working for anyone. Let me see if there's something out there that may be better. And that led me down to the path of direct primary care, which seems to be better for both parties. It's happy doctors, happy patients.
So before we go further, let's discuss some definitions in terms of what direct primary care is. I've had several direct primary care physicians, but for those listening who aren't familiar, just give us a 30-second definition of what that is.
Sure. So the 30-second definition is that it's really authentic and genuine family medicine. Patients pay a low monthly fee, generally between $50 to $100, in exchange for health care, and the doctor doesn't bill insurance. So patients can come into the office with unlimited office visits or video visits without any additional co-pays or visit fees. A lot of times they can text, call, or email their doctor directly, and a lot of other things are included in that $100 or $50 a month. Things like in-office testing, like strep tests, COVID tests, flu tests, urinalysis are included. Procedures like joint injections, stitches, abscess drainages, toenail procedures are included. So there's no additional fees for all of these things. And then we provide better access and better affordability for things like medications and labs. So a lot of direct primary care clinics dispense medications right from their office for at cost pricing, so they don't profit off of it. And the same for labs. So most of the blood tests, like the common ones like a CBC or CMP to check blood counts or kidney, liver, electrolyte, those kind of things, are between $5 and $10. And there's no sort of barrier between patients and their doctor about ordering these tests.
And to be clear, this is in contrast to what's known as concierge medicine, where you hear like these fees of $2,000 to $3,000 per year, correct?
Correct. Yeah. So very common question, or anytime you say there's a monthly fee, it's a membership based model. A lot of people sort of say, oh, well, I can't afford that. That's for the rich. And direct primary care is really not like that. So both concierge and direct primary care, they give excellent care, right? So you have better access to your doctor, you get a doctor that knows you, but really the difference is the money and the way that insurance is used. In concierge medicine, the fees are higher, generally double or triple the monthly fee. And then also patients still have a copay or a visit fee when they see the doctor, and then they'll still get a bill from their insurance for the visit. Whereas direct primary care, there's no copay, there's no visit fee, and they'll never receive a bill for their insurance. But direct primary care clinics can still use insurance when it's necessary. So we can still send a medication to a pharmacy and have the pharmacy bill the insurance, or send a lab to the actual lab and have the lab bill their insurance if that's what's advantageous for the patient. But a lot of times, probably 80-90% of the time, this primary care stuff is cheaper and more easily accessible without bringing insurance into the picture.
Now, most of the direct primary care physicians I talk to, it's always a story of them practicing in the traditional system and then they get burnt out after 10, 15 years of practice and then they switch over to direct primary care. So you're a little bit different that you went straight out of residency into direct primary care. So tell us what kind of exposure you got to direct primary care during your residency training to make you want to really explore that path.
So actually, when I was a second year is when I first sort of heard about direct primary care from a YouTube video by Dr. Ferrego. And that video just sort of opened my eyes a little bit and made me reach out to other direct primary care doctors who were close to my residency training site. And so that made me just reach out to them to see if I could do an elective rotation with them. And so I ended up doing an elective rotation in direct primary care and fell in love with it. And when you're in residency or when you're in a healthcare facility or in when you're doing anything in medicine, you come across people that are burned out. And so you're sort of every day you're seeing what your future could look like. And to me, I knew that that was the path I was sort of leading down. And so I'm very, very thankful to have stumbled across direct primary care.
And when you made a decision to open your direct primary care practice, what was the reaction from your colleagues, your
Mhm.
program director? Did they have any doubts? Or were they asking you, "What are you doing?" What was their reaction?
I think everyone else, including myself, but if you don't have doubts, then I don't think that you're being realistic either. So that's sort of expected. But definitely a lot of doubts. I think a lot of the doubt comes from not really understanding it.
Yeah.
But once you understand it and realized how affordable primary care is, and the fact that I don't need a patient panel of 3,000, 4,000 to earn a living, it really just sort of brings everything into focus and makes it easier to understand.
All right. So take us into that transition. So you finish your medicine residency and you open a direct primary care practice. So tell us what happened next. How difficult or easy was it to build up that patient panel?
So it was pretty difficult to start out with, but then has sort of snowballed into it being, knock on wood, fairly easy at this point. The reason that it may have been a little bit harder for me is that I moved I'm from North Carolina, trained in Pennsylvania, and moved to Southern California. So I wasn't a known entity. I didn't have a lot of family or friends. And so that was something that was sort of working against me. So over the first 2 months of opening, I had one patient sign up. And my goal for the first year was to have 100 patients. And now 6 months in, I have about 140 patients. And so the snowball effect really, really happened. Sometime in January, I started to advertise a little bit more on social media and was starting to have 20, 30 patients sign up per month. And now, basically, almost a year, not even a year into it, word of mouth is really starting to pick up. Patients really, really love this service, and people just love talking about what they love, right? So I have a lot of my patients talking to their friends and family, and even if their friends and family don't sign up, it's interesting. And so they'll talk to other people about it. And eventually, somewhere down the line, I'll have a patient sign up. So the first 2 months was hard, just sort of getting my name out there. But since then, thankfully, it's been a steady 20 to 30 new patients a month.
Your Kevin MD article is titled Direct Primary Care, More Access, More Savings, More Care. Take us into a typical day of a direct primary care physician. What's your typical day like?
So I usually get to the office around 8:30 and check emails, make sure no one had any questions overnight that they emailed me because, a big part of the model is that patients can directly contact their doctor. And so I get text messages and emails and phone calls from patients fairly frequently. And so that's the first thing I do when I get in the morning. And of course, I set barriers with patients too, so it's not too much of a burden on me. But at the same time, I want them to know that if they feel like they need a doctor, to not hesitate to reach out to me. So that's the first thing I do. And then maybe I'll see a patient at 9, and that visit may go until 9:30, 9:45. And then maybe I'll have another patient come in for a blood draw. So I'll draw their blood and then they'll leave. And then maybe I'll call some patients and talk about their lab results from last week. Then I'll have a patient come in and pick up their medication. And then at maybe 11, I'll have a new member patient, and my new member patients are 90 minutes long. So we really get to set a great foundation for their health moving forward. And I'll draw their labs too. And so that takes us to about 12:30. Then maybe I'll take 30 minutes for lunch, do the notes, and just, so that's pretty much how the day goes throughout the rest of the day. And then maybe I'll get a phone call with a patient that's having some burning when they urinate or some lower urinary tract symptoms, and then we'll come in and test their urine. And so it's very similar to a typical flow of primary care where you're seeing a lot of different things. I would say it's more personal because I know
Mhm.
pretty much everyone that comes in. I get to spend more time with them. And I feel like I am actually doing more versus just what I was doing, where it was, here's your CBC, CMP, here, see you later. Now it's really talking about all those things and being able to offer them all in the same place too.
One of the features, of course, of direct primary care is that patients have increased access to you, phone calls, text messages. How obtrusive is that? Are you getting texts in the evening? Are you getting texts during the weekends, during family time? What's that like when you're not in the office?
So far, it's been okay because I really I try to set barriers with patients from the very beginning. So from the first sort of new member visit, I go over when they should call me, when they should text me, when they should email me. And the conversation sort of goes like, if you're having left-sided chest pain that's radiating down your left arm into your left jaw, you can't breathe, call 911. Don't call me because I'm just going to tell you to call 911. But after you call 911, then have a family member call me and let me know what's going on. Because if I have a patient that's going to the emergency room, I do want to know about it. That way I can talk to the emergency room doctor if they are having a hard time finding out about the patient's health care, or I can even go to the emergency department with them if I'm not doing anything else. So that's the first thing I tell them. The second thing I tell them is that if they twist their ankle really bad, or if they're cleaning and they get some Clorox in their eye and they're not sure if those things are something they should go to the emergency department for, then they can call me first and we'll talk
Mhm.
about it. Maybe it is something you need to go to the emergency department for. Maybe it is something where, okay, it's 10 p.m., but this is important. I need to meet you in the office right now to save a trip to the emergency room. Or maybe it's something that you can do this and this and this at home and I can see you the next day. And then the third sort of scenario I tell them is, if it's 2 a.m. and you just can't sleep at night, well, then don't call me because then I won't be able to sleep, and it won't be good for anyone. But instead, write me a really long email about why you can't sleep, what things you've tried in the past, what's hasn't worked for you, what's worked for you, what you're thinking about, what you think might be helpful. And then that way we can schedule an appointment and go over that long email. And at the same time, I let them know things like scheduling appointments or medication refills, those sort of things are best in an email instead of a phone call or a text message, because I know I won't miss their email. But if they text or call me, it might slip through. And that may happen, but that also sort of pushes the patients into using my preferred method of communication, which is email.
Now, for those residents who are in primary care specialties, family medicine, internal medicine, and they're listening to you, and maybe they're considering a direct primary care practice just straight out of residency, just like you did. What kind of questions should they ask themselves to see if they're really the right fit for that path?
That's such a hard question. I would say, would you rather try something and it fail, or not try it and always wonder what would have happened if I would have tried it? Because that's sort of what I asked myself. I said, okay, so I want to try this direct primary care thing, and if it fails and I lose some money, then that's okay. At least I can live with myself and saying that I tried to do something different, versus if I would have just stayed down the path that everyone else chooses. Every day I would have gone to work, I would have been wondering, what if, what if, what if. And so that's what ultimately made the decision for me. And ultimately, in residency, reach out to direct primary care doctors. I mean, we're such a small, we're not really small, but we're such a close community, and we're so ready and available and willing and wanting to help residents learn about direct primary care, just reach out to someone in your area to see if you can shadow for a day if that's all you have, or do an elective rotation, and I guarantee you'll find someone.
What about the burden of student loans, right? A lot of medical students, they graduate and finish residency with hundreds of thousands of dollars of student loans. Does that play a factor in the decision of whether to go into direct primary care, where it may be a little bit more financially unstable than going the traditional route?
So that's where I've gotten really lucky. For one, I bought and sold a home and residency at the perfect time. So I ended up getting a lot of capital from that. The second thing that I'm lucky with is that my wife is also a physician. And so we do have still a stable income. As far as student loans, I'll be on an income based repayment plan. And so that, and so far it hasn't even started yet. Right. So that is something that I'm somewhat worried about, but it's going to be income based. And so I'm not overly worried about it. But that's definitely probably, I would say that's the number one thing that has been the toughest about being a direct primary care provider and starting out right out of residency, is that you go through residency and you're ready for your ascending salary. And where me, I'm over a year out of residency and I still haven't paid myself yet. The practice is doing really well. I'm meeting overhead, but everything I make is going back into the company. And next year I'll probably make maybe 100 to 120,000, and then the next year maybe 200 to 250, and then so it's going to take 3 to 4 years before I start paying myself a physician salary, and that's tough because all through residency you're struggling and you want the new house, you want the new car, you want all these things, and so that's been the toughest struggle for me, even with having a spouse who's a physician. And in California, I guess that doesn't really mean
Yeah.
much.
So as you reflect, you're still at the beginning of your journey. So as you reflect, like I guess during training and when you made a decision to go to direct primary care, is there anything that you would have done differently? Is there anything that surprised you? Just reflect on that path.
There's not much that I would have done differently. The Probably the most surprising thing is just how appreciative patients are for the service that I provide. When I text a patient just to check on them the next day, they are elated and they're just like, "Oh, it's so cool that my doctor texted me." They love it. And the other thing that surprised me is honestly how fast the direct primary care has grown. 140 patients in about 8 months is outdoing my expected pace, and it's all because of how much patients are loving the concept and the care. So that's been the most surprising thing to me.
We're talking to Landen Green. He's a family physician, and today's Kevin MD article is titled Direct Primary Care: More Access, More Savings, More Care. Landon, tell us some of your take-home messages that you want to leave with the Kevin MD audience.
For the fellow clinicians out there, if you're struggling, you're on the brink of burnout, just, Google, look into direct primary care, talk to direct primary care providers in your area, and see if it could potentially be a pathway for you. It's not for everyone, and there's a lot of reasons why it may not be a pathway that you can decide that you can go down, but I would at least encourage you to check it out. And for the patient audience, same thing. Just check it out. There's no harm in going to a meet and greet with a local direct primary care doctor near you, or just Google searching direct primary care near me. There's no harm in doing those things and checking it out. Most direct primary care memberships, there's no long-term contract, so you can try it for a couple months, and if it's not working for you, then there's no hard feelings. But if I had to bet, I would say that you would love it just as much as everyone else.
Landon, thank you so much for sharing your story time and insight, and thanks again for coming on the show.
Thanks for having me, Dr. Fo.